Good morning, everyone. My name is Dr. Adil, and today, as recently we have covered diabetes mellitus, so today we are going to talk about diabetes insipidus. What is diabetes insipidus? This is basically the order of ineffective ADH. What is ADH? It is anti-diuretic hormone, and it is also called as vasopressin. So, as you know, what is the function of ADH? It is anti-diuretic hormone, which means like whenever this hormone will be released from the pituitary, so it is going to stop uh, the formation of urine, or simply it is going to conserve the water inside the body. It works in this way that whenever, for example, someone is not taking enough water. So when you're not taking enough water, what will happen that your body will go into um, like towards dehydration, but this hormone will be released, and this hormone will act on the kidneys, and the kidneys will start conserving water for the body, or you can say less formation of urine or less loss of water in the urine. So, whenever either this hormone, antidiuretic hormone or vasopressin, is absent or deficient, or there can be one more thing like either it is deficient, or uh, maybe the hormone is there but it cannot, like the kidneys are not responding to that, or you can say there is resistance, peripheral resistance to the hormone. So the condition which we will develop is called as diabetes insipidus. And see, what are the signs and symptoms of this condition is simply when you don't have enough ADH in your body, or the ADH is there but it's not acting on the kidneys. So uh, there will be diuresis because it is anti-diuretic hormone. So there will be diuresis, and the kidneys will keep on forming more and more, or you can say large volume of urine. There will be large volume of urine, which is basically diluted. Okay, diluted large volume of urine. So what happens in diabetes mellitus, for example, is the person feel more thirsty and they drink more waters, or simply there is polydipsia and polyuria. So what's going on in this diabetes insipidus is polydipsia and polyuria. The person who have diabetes insipidus, they keep on drinking water and they keep on losing water. So that's why this condition, I'm like this condition I am uh, teaching you in continuation of diabetes mellitus, because the sign and symptoms are same. And that's all. There is one more condition, which is called as psychogenic polydipsia, which means someone who is drinking too much water. And of course, like when you drink too much water, there will be more urine formation and there will be more urination, and the person will keep on going to urinate again and again and again. So uh, like the important thing to understand here, like in diabetes mellitus, in diabetes insipidus, and in psychogenic polydipsia, one of the clinical feature which will be same in these three conditions will be polydipsia as well as polyuria. And for example, if a patient will come to me and he's like 40 years of age, um, I can write over here, uh, like this is a case. For example, a patient came to me. Okay, patient came to the doctor, and he complains of polyuria polyuria and polydipsia. Like the person is saying that, I drink a lot of water, I urinate a lot. So, what should I think of logically? So, of course, like one of a very, or simply like what will be the differential diagnosis? What will be the differential diagnosis which will come into your mind being a working doctor? The first thing you are going to think is diabetes mellitus, that maybe the patient has having diabetes mellitus. You will think of diabetes insipidus, or you will think about psychogenic polydipsia, because three of them, they have the same clinical features. So you can see this one in normal patients. People, what happens, like the pituitary gland sends a hormone called as ADH to the kidneys, which help in controlling the urine which is formed. See, the urine is concentrated, dark, and lesser in amount. Whereas a person who has like what is central diabetes insipidus? Like DI, central DI is simply the pituitary is not making the hormone enough, but there is a peripheral kind as well, in which this one is making hormone, but the hormone cannot act here, or the kidneys don't give any response to that hormone. So what happens in this one? His this person kidneys will keep on making more and more like large volume urine, which will be diluted. So you can see in this glass, they show like the glass full of urine with and the color is not dark, okay, more watery type of look. So moving forward, again, this is the thing which I'm talking about. There is central diabetes insipidus and there is nephrogenic diabetes insipidus. And causes, central diabetes DI can be caused by, of course, like what is there in this one? There is like deficient, or you can say insufficient hormone, okay, or ADH simply, which could be due to surgery, due to head trauma, due to pituitary or hypothalamic tumors, okay. The tumors can be hyperfunctioning, can be hypofunctioning. So of course, a hypofunctioning, or a tumor, for example, which is there and it is compressing uh, the pituitary gland, and it is not letting the pituitary gland to do its function. Intracerebral occlusion or infection. There are many, you can say, not so important, but the conditions, like there are many other, for example, um, some people have familial DI as well, like it runs in their families, and histocytosis X is also one of the cause, but not so important. Whereas you can say the nephrogenic diabetes DI, in which like the hormone is there, but the kidneys are resistant, okay, to the hormone. They don't respond to the hormone. So now the causes of this can be many. See, there can be systemic disease involving the kidneys, multiple myeloma, sickle cell anemia, polycystic kidney disease, pyelonephritis, medications such as lithium. Okay, so there are like all these things can cause hypercalcemia, as well as hypokalemia can be there. And the third one, as I told you, that is psychogenic DI. We are going to cover that. So, guys, I don't think so. I have to revise like this thing. Like this one is showing the central one. There is no ADH, and the urine will be dilute as well as positive. Like the water will be released a lot, whereas in nephrogenic one, the hormone is there, but it is not acting on the kidney. Okay, so let's go to the signs and symptoms of this one. Simply, if the person is complaining that they have polydipsia and polyuria, so what it means, like they are producing large amount of urine, like in this one you can say over here like 5 to 15 liters per day daily. Um to tell you more about the urine formation, a normal person, average. Of course, like it depends on how much water you drink, but a normal person produce somewhere between 750 to 1.5 liter of urine average, okay, each day. Of course, if you are going to drink more water, so you're going to produce more, and if you're going to drink less water, so you are going to produce less urine. So you can see over here, like this is the main, you can say, thing which you are going to see. So they pass large volume of dilute urine. They have polydipsia. They have heart dehydration. Okay, and if, for example, because they produce a lot of dilute urine, so and if they keep on losing that water and they are not taking enough water, so they may have this dehydration. Okay, and the signs of dehydration are written over here, like their mucous membranes will be dry, skin will be dry, there will be weight loss. But one thing which I should add here, there will be hypernatremia. Okay, they will be having what? They will be having hypernatremia. So simply increased. Oh, this is too much big arrow. So simply they have hyper sodium will go high. Okay, increased sodium levels in the blood. So this is how what you will find in their blood. So I think you understand what I wanted to say. If you're losing a lot of water through urine, or you can say uncontrolled loss of water from the body, and you're not taking enough water, so what is going to happen? The person will develop dehydration, and the kidneys, they are not losing water with sodium. It's just water which they are losing, so they will be having more sodium inside the body, and they develop a condition called as hypernatremia, like increase, you can say, sodium levels in the body. Okay, diagnostic test is very interesting in this one as well. Um, See, when they lose a lot of water from the body, so their plasma osmolality, which is around 280 to 295 milliosmol per liter, so in this one, it will be increased because their blood will become concentrated. And when you will check their urine, because the urine is too much dilute, so you will found that the urine osmolarity is very much low, okay, in these patients. And of course, if when they will develop dehydration, you will find that their blood urea nitrogen will be increased as well because of concentrated blood. And like this is the thing which we check. So now the diagnostic test is interesting, as I was telling you. See, one of the diagnostic, like to make the diagnosis, what we do is like we do something called as fluid deprivation test. See, if you are not letting someone to drink fluid like water, if they have psychogenic polydipsia, when you are going to restrict, give less fluid, okay, or less fluid intake, not give, like of course you cannot stop someone, so less fluid intake, okay, in anyone will lead to less urine formation, okay, and the urine osmolarity will be normal. So this is the case of psychogenic polydipsia. But if you are giving someone less fluid intake and their urine is still diluted, it will make up the diagnosis of what? Diabetes insipidus. Okay, so this thing is important. So once we deprivate anyone with fluid, okay, So if the urine output is still higher and urine osmolarity is still lower, then it is diabetes insipidus. But if you are not giving someone fluid, or you are restricting their fluid deprivation test, so their urine osmolarity will increase and their urine volume will be decreased. That is the case of psychogenic polydipsia. Now, when you had done the diagnosis of diabetes insipidus, then the next step is to find out either it's central or it's peripheral diabetes insipidus. Okay. So what I mean to say, like once like you know now this the case, so you have to see like either it's complete absence of ADH or either the ADH is there but it's not acting, then we will move on. So how we do what we do that, how we differentiate that? Simply, we give them ADH, or it is also called as DDAVP. Okay, when you provide someone with ADH, okay, and they respond to that, what it means, when you give ADH and you found that the condition is getting better, so what it is central DI. But if there is no effect, okay, responding to ADH, central DI. But if they are non-responder, not responding to ADH, then it is with what kind? It is peripheral DI. So this is how we diagnose. Okay. So then there is management. Management is so simple, guys. The objective is to replace ADH, to ensure adequate fluid replacement, to identify and correct the underlying cause. What it means to say is like all the causes which we go through them here. If you found some cause over here, like you found that someone is taking drugs like lithium, stop that. Okay. If someone have multiple myeloma, treat that. Things like this. Okay. So treatment is of course like to identify the underlying cause, to treat the dehydration, and to replace the ADH in case of central DI. Okay, so how we replace the ADH in central ADI? Simply by giving DDAVP. Okay, of course for central one. So this is the important thing. Okay, if someone have peripheral DI, then you can give different drugs. What we do in these patients who for peripheral DI is like, or nephrogenic. Peripheral DI is also called as nephrogenic because the problem is here is in the kidney. So treatment for nephrogenic DI. So what is done here? First of all, we restrict them for salt and protein intake. Okay, and we give them thiazide diuretics. Okay, because what thiazide diuretic do? It deplete the sodium and increase renal water absorption. Okay, so these things can be given. By the way, other than thiazide diuretics, one more drug which have the same function like this is NSAIDs as well. So we can give this one. So like very easy topic, guys. Very easy treatment. Diabetes insipidus. It's not so hard. It's not so difficult. So this is about what you can say diabetes, insipidus. Now we are going to cover some other topics which are related to endocrinology. Okay, so of course, like the rest of the topics are not so important. They are important, but uh, like not as important as thyroid or diabetes. Like they are the most important one, high yield topics. So I think like in the next lecture I will continue with that.